Welcome to this video on the new normal virtual clinics post-COVID-19. Please share your thoughts in the comments and subscribe and turn on notifications to ensure that you don't miss any new content that we upload. My name is Hope Frost and I'm delighted to welcome you to this webinar, The New Normal Diabetes Virtual Clinics Post-COVID-19. On behalf of SBK Healthcare, I'd just like to say that we are so proud to have produced this event and we do hope that you find it useful. I'd also like to thank Abbott for kindly sponsoring this webinar. It is now my pleasure to introduce your webinar host, Professor Ramzi Ajjan.
Good evening, everybody. My name is Ramzi Ajjan. I work in Leeds and I'll be chairing the meeting today. And it gives me great pleasure to introduce Pratik Choudhary, who's a senior lecturer in London, but there is a secret that I need to share with you. Actually, Pratik is going to be the professor of diabetes from August in Leicester. And I must say that Leicester is very, very lucky to have him. The second secret that I would like to share with you is the fact that I've known Pratik for almost 25 years, around 23, 24 years. And when we first met, obviously, I was around 11, he was 3. And we worked in 2 different areas of research. And I never thought that we'll end up 25 years later talking about or contributing to sort of a similar subject. Without wasting too much time, I'm going to hand over to Pratik to start our webinar today.
Thank you, Ramzi. And when you didn't think that we'd be doing this together 20 years down the line, it means that when we met all those years ago, you really didn't think I was going to make any big shakes, did you? The title of the webinar today is The New Normal Virtual Clinics Post-COVID, but actually I'm going to take that quite literally and make a rather broad comment over the next 30, 40 minutes or so. And I think COVID-19 has really impacted patient experience, especially with long-term conditions. There's certainly been reduced access to care, with a lot of us having to cancel clinics. There's been increased risk and a lot of anxiety around that, with the comments and documentation of increased risk of death and mortality from. What I was going to say was that, as I said, there's been reduced access to care, increased risk of people with diabetes, psychosocial impact, people being isolated, worries, a lot of anxiety. We've had quite a few patients actually when we've offered them opportunities to come into face-to-face appointments, they've been anxious about coming into hospital because it's seen as a hotspot for COVID. And then, adherence to treatment could have been difficult, especially for those struggling. Having said that, I have seen a couple of papers showing that glucose control has got better overall for people during lockdown, maybe because life is less complex. But when COVID hit us, and certainly I work at King's, and I think we were one of the first hospitals to have a major kind of reaction to COVID, that when we sat down with the team, there were 5 major areas that we had to think about and consider. There was the urgent support, which is for our vulnerable patients, preventing admissions, getting information on sick day rules out to them, people with pump failures or whatever, people with mental health and diabetes issues or acute complications, foot complications, managing those people and keeping them out of hospital, providing them with some support. Then there was a second category of people where we needed to manage the admissions coming in. We were seeing a lot of atypical presentations. I'm sure you've seen DK and non-diabetic people or people with type 2 diabetes coming in with very high insulin requirements. And so there was a push towards supporting inpatients from the team, which increased our workload. And then once people were better, there was a big push to send people home very quickly. We wanted to minimize their stay in hospital, but then you've had people, a lot of new starts on insulin that we had to manage as their requirements seemed to drop off quite rapidly over the 2 to 4 weeks. And so we had to facilitate the discharge, get them taught insulin and glucose monitoring, but then also manage them quite quickly as the requirements tapered down as they improved. And then there's a whole chunk of work around our normal caseload. We had about 2,500 patients in our category. And then we had the special groups. We deal with a lot of post-transplant diabetes, dialysis patients, and CF-related diabetes. So we had to create a strategy, as I'm sure you all have had, for managing all of these categories of people. This is kind of what we came up with. And just to walk you through here, we knew there was going to be a whole bunch of existing patients, but new referrals won't stop, and they would come from primary or other colleagues. We had a lot of people waiting to see us actually who'd moved to London in the 6 months prior to, or 2 months prior to COVID. And then we had our discharge team, again, who would be new patients coming into clinic. So we managed a consultant-led triage of some people were straight discharges and some people were straightforward deferrals, who we sent a letter routinely to everyone with resources to look at, sick day rules, and who to contact. And we triage them into a holding list that we would use when outpatients restarted, because we had to stop all outpatients completely. Sorry. But then we had to manage people with hot urgent issues. Some of them would need face-to-face, where we need to do blood tests, or they just didn't have the technology, or it's just not appropriate for them to be seen virtually. There's a second category where patients need a blood test, but that can be managed locally from the GP, where the GPs were open. That was an issue as well. And then a large chunk of people who had these hot or urgent issues who we saw virtually within the diabetes, or DPPS is our diabetes psychology service. But in some of those people, we were able to see and defer with advice. So it was quite important for us to have that stratification in our mindset about how we would deal with things. Diabetic foot pregnancy and early discharge clinics remained active throughout the whole process. And so now 3 months down the line, as we are trying to get back to our regular service, I'm sure we're experiencing something that a lot of you are experiencing, which is we've got 3 months of missed work. For us, that's about 800 missed appointments. Then within our patients who were stratified as being high risk or hot patients, there's a whole bunch of people who we were not able to reach. So you've got someone who had a high HbA1c or poor renal function who needed to be seen, but we just, address, phone number, we tried everything, we can't get hold of them. Within that, we did notice that there's a lot of lockdown relocations. Certainly we experienced a lot of people, young people went back to their parents, people it was almost like the wartime effort where people moved out of London into the countryside. And so, even if you're offering, you didn't have the right address or the right telephone number because they'd moved away. Now in our recovery phase though, one of our challenges is reduced capacity, because even though the initial push of all our clinical consultants doing a lot of frontline COVID work has reduced, we still have an increased GIM commitment, about a 25% increased rota commitment, increased wards and things. SPRs are doing a lot more intensive work, and because hospitals moved to a 7-day working, that means people are having to take 2 days off in the week. No leave is granted during your GIM commitment, so that's all the leave comes in specialty commitments, and no one's allowed to take leave since January. So we've got a lot of gaps in the next 4 or 5 months. So these are all the sort of things that are coming in where you've got a big backlog and a reduced capacity going forward. The other issue, and I was on an ABCD meeting earlier this afternoon, and it seemed like a common theme, is reduced physical space. So certainly in our hospital, we've been decanted out. Other areas that were freed up for COVID, pushed surgery or gastroenterology or specialities where they need to poke and prod the patient and physically see them, were decanted into diabetes clinics. So we actually, when we're trying to restart our service, we have a very limited availability of clinic rooms to go back into to see people. And even when we do go back in to see people, trying to keep the 2-meter rule, we are trying to work to a 25% capacity of our outpatient building, which means immediately that, well, if you're scheduling a list, that means if your list had 8 patients, you can only see 2 face-to-face, and the other 6 will need to be virtual. So, these are issues that are going up and down the country. When referrals are coming in, community services were stopped, and so normally if someone was, HbA1c was high, type 2 diabetes, we might be referring on for GLP starts or insulin starts in the community, but those services again have the same issues of reduced space, reduced capacity, and a huge backlog. There's lots of anxiety, as I mentioned. The patients coming to clinic. We've not had any Daphne courses, and there is a virtual Daphne being trialed shortly. But again, the whole administration side of this and setting that up and how it will work remains to be seen. Many of the hospitals, a hospital like ours, we have about 700 pump patients. So we do about a third of those, maybe up to 200 pump starts or renewals a year. 3 months of activities, at least 60 or 70 people haven't been restarted on pumps. So there's a lot of little bits that we need to take out when you're planning that recovery strategy. And we're trying to plan it in a way that will have reduced requirements. So I've been part of a number of different groups, organizations trying to put out some guidance and support and stop everyone reinventing the same wheel. And so just a couple of days ago, we issued this recovery guidance that I was part of a group within the ABCD to develop. So it's on the website, you're free to have a look at it. And on that, what we did was we put out what the criteria we developed as a group, and that included people from Diabetes UK, people from PCDS as well, about the risk stratification of patients. And if you are a service where you've had 3 months of gap of service, then you really need to go back and look at those people and see who are those people you need to see in the coming months, because of those people who are in that red category. So our suggestion or our guidance is that those people in the red category we need to see within 3 months. People with the amber category by the end of December. And if you're in the green category, maybe the expectation is that you're not seen until December, because we need to make sure that we've covered our backtracks in case there is a second or something. We know that the risk factors and COVID are mainly age, which we can't, gender, which difficult to change, but the main modifier, ethnicity, which again we can't change. The main modifier risk factor is HbA1c, associated with worse outcome. And I think that's why in this next 6 months, while there remains an active threat of COVID, if you like, I think we really have to focus our efforts on working with those people in the red and amber categories. And so for red, we've put an HbA1c of 10%, amber 8.5 to 10%. These are based on the cutoffs within the data that came out from NHS England. I've got some alternatives there for time in range, A1C of 10% or less than 30% time in range, uncontrolled hypertension, down at hypoglycemia risk. You see someone with a severe hypo, again, we need to access those people. Impaired awareness in the amber group, normal in the green. And as you move forward, again, kidney function was a big risk factor there, as you can see. So if someone's got a GFR less than 30, I think they do need to be on a regular follow-up. If people have had aggressive albuminuria or GFR 30 and 45 in the amber group, and normal GFR in the green group. And again, risk of admission, anyone with previous admission, cardiovascular or DK or unstable glucose, again, those are people who we need to prioritize to see. Now, one of the challenges there, this is a paper that we've just submitted again, called the Roadmap to Recovery. And one of the challenges here is, okay, it's very good for me to say that in the next 3 months through July and August, as you recover your service, focus on the guys in the red group. But the question is, how do you find them? Because actually, the only easy way of finding them is if you have a diabetes database. You need an integrated IT system, ideally that crosses primary and secondary care, that will help you triage patients and access and get in touch with those patients who need care the most. The second bit is that it's really important that we see the right patient, that we triage them, and we focus our attention on those who need our services the most, in the right place, whether that is virtual or face-to-face, and you can't really mandate that, and at the right time, which is when they need to be seen. It's very hard to mandate that all reds need to be seen face-to-face, because actually I'll show you, you can do you can access those people and help them a lot, even with the virtual. And all people in the green category, maybe they don't need to be seen well, maybe they do need to come once a year for their annual review and checks, or maybe they are someone who doesn't have access to technology. And so it's a very individualized decision. The other thing that I think this is teaching us is something that I've been keen on for a long time, which is needs-based follow-up. Because for too long, we've been in this cycle of, well, I've seen someone follow up, see you in 6 months. And the 6 month follow-up, yep.
Pratik, can I just interrupt and ask you a quick question? The mental health doesn't sort of feature here, and I just wondered what your views are on this, because this is particularly in the younger population, can be an issue. So I just wondered.
Thanks, Ramzi, and I'll go back to this slide actually, because the first draft of this, imagine how many drafts it would have gone through to come out, had mental health in the red. And in King's, we measure diabetes distress at every visit. So it's quite easy for us to say, right, if your diabetes distress is 6, you were in the red category. But the more we thought about it, the more it became clear that actually those people who have we know that actually people of high distress actually end up having high A1C, or problems with hypos, or recurrent admissions. And so a lot of those people who are worried about their mental health get picked up by the other biochemical markers. And actually, if you're trying to triage people on the basis of mental health, those records we thought for a national level document, I mean, we measure diabetes distress, but there's 140, 200 people online now. How many people will be able to look through their patient list and say, and identify those who have mental health issues that challenge their diabetes? And so I think you could accuse us of being a bit cruel. We said, okay, if you are highly distressed, but your glucose is okay and you're not at a hypo risk and your kidneys are okay, then we'll have to prioritize those people where those issues are causing high glucose and biochemical issues that lead to admissions. But if these are guidance, right? And if, being under the care, I had a category there, under the care of our diabetes mental health team, as being at least an amber category.
I mean, you can certainly not include everything. So I completely understand. So you've got a surrogate marker for mental health, if you like. Yeah. That's what you're saying. Yeah.
I think the HbA1c is a surrogate marker for mental health for sure.
Yeah. Okay.
Yeah. And so, so I think at the moment, one of the thoughts we had was moving forward, what is a very logical thing to do would be to get together with local network leads in primary care. Because a lot of those network leads, primary care services, can run searches at practice levels using either retinal screening lists or using the EMIS or System 1 database that they have. Because actually they report back to the diabetes database. And even if you could just get that to find out which of the people have got the high A1C, cross-checking with hospital, that might be one of the ways in which you prioritize either within your specialist service or within your community service, people who need to be seen. At King's, we don't have a database like System 1 or EMIS or any of these other ones. And so actually we did it all manually, where we, at the time, we balanced out the effort, but rather than just see everybody, we spent some time just scanning through clinic lists, identifying those, triaging everyone into red, amber, green, and then we knew what we needed to do for the next 4 or 5 months. So we thought that was an efficient use of some of our time, in a sense. And then we also put together, and I don't know if people will agree with it, just some guidance to help them judge. Because if you are in a red zone, A1C above 10%, recurrent severe hypos, that person can't just have one appointment in the next year. That person would need, over the course of a year, when we go back through our data, and actually I had a BSc project last year where we looked at people who met those sort of criteria, how often they're seen, and it's about an average of 5 to 6 times a year that they'd have a nurse or doctor contact, and maybe a couple of those are face-to-face, maybe they could all be virtual. It doesn't really matter as long as they're getting frequent support. People in the amber group, maybe 2 to 4 appointments or contacts through the year. And if people are green, maybe they're okay to be seen on a yearly basis. But really importantly, you'll see that bit, need rapid access support as needed. So if you are pushing people out, it's really important to have a landing space for them, an email address. And one of the things we did was we send people out information, particularly the people who are in the green categories, saying that, we're really sorry. We're having to divert our attention. I'm sure you understand. You've been doing really well. Keep doing what you're doing. Here are some resources, whether that's the DTN website, whether that was the DUK guidance website, sick day rules. And here's an email address that if you answer, we'll try and get someone back to you. And we dedicated a little bit of our time to manning that email address so that the people who were not seeing had access into healthcare support. And we tried to get a response back within 24 to 48 hours. So when you're mapping your availability of people, we highlight a bit off for the email response, a bit off for triaging, and then a bit off for delivering the virtual care for those people in the red zones. So just some ideas. I'm not saying it's the only way to do it, but that's just the way we planned it out, I think. The other thing I want to bring to your attention is we were aware of people coming into hospital with these high insulin requirements and then starting insulin rapidly and needing to get home on IVIs where people were in full PPE, and how do you check glucose? So we started a discussion with Abbott and we became aware that in the US, the FDA had rapidly approved both Abbott and Dexcom for inpatient monitoring. And so after some negotiation, we managed to, Abbott very kindly agreed to donate 6,500 Libre sensors. And I think now most of those have been allocated. I think there's been a fantastic response from, I'm sure, people on this call. And the key focus of this was to facilitate the safe and rapid discharge of insulin treated patients. Because we know when they went out, if you can access LibreView, you can see what's happening. And in particular, there's this group of people who were started on insulin rapidly because of high requirements due to COVID-related disease. And those requirements are rapidly coming down. And so you've got about 2 sensors, gives you 4 weeks worth of options to follow these people remotely, by which time they will have stabilized. In the next few months, you might see a lot more people with COVID admissions going on to dexamethasone again, where their requirements will go up. They might be discharged on some steroids, and again, we'll need tapering out. And so that ability to monitor them remotely and safely for 4 weeks will be quite valuable. The second, maybe, and not all hospitals would agree for this, but we thought there's some value in people on COVID wards where you're using PPE to measure glucose contactless. Although I'm aware, I think if you ask 5 people, you'll get 5 opinions on how safe it is to manage a VRI on a sensor glucose. I think we all have our opinions on that, but a lot of that will be related to local clinical governance about when extra SMBG needs to be performed and when you can rely on the sensor readings. And so really, and I'm putting this pathway up primarily because in the last 2 weeks, I've heard of a few comments from CCGs raising concerns about DTN pushing sensors and raising expectations for patients that they will be able to use sensors a long time, those people who don't meet the current criteria. And it comes to mind that I think clinicians, we all are aware what the criteria, and if you were in hospital with someone who's with type 2 diabetes, gets put on dexamethasone, his COVID gets better, and steroids are going to be tapered and they're being discharged, to monitor them, and you have this ability to monitor that remotely and get the data. The benefit of that shouldn't be outweighed by the fact that that person might then want to have a Libre all the time, when if we make it really clear to patients that this is not for long term, this is for the 4 weeks just while you stabilize. And I think that's why in our pathway for the new start, I think although you can put the Libre on to get them out, they need to have training on SMBG as well. And they need to be aware that once these 2 sensors run out, this is a safety project, if you like. And I think if you're having people having discussions with their CCGs, they should make it clear that we all are aware what the current guidelines for sensors are. But this is a safety issue that shouldn't come in the way of what is a good initiative, I think. Ramzi.
Pratik, can I ask you, the divide between the type 1 and the type 2, what percentage were type 2s? And my second question is related to a question that came in, which I quite like actually, by Rob, who asked, how was ANG, advice and guidance, facilitated for primary care? Because that links in with this quite a bit, doesn't it?
It does. So I think the advice and guidance stuff, if I go back to that, I'll take that bit first. So this is the advice and guidance of the referrals coming in. And so effectively what we did was we had the luxury, a big team. So while all my colleagues who routinely do general medicine were all pulled and sucked into the GIM wards and COVID and full PPE, that left me with a couple of research fellows and one of our nurses who was shielding to manage all our 2,000 patients. And so we just took it upon ourselves to take the advice and guidance things and try and deal with the things that we can, and we dedicated time. So if you can imagine, what we did was we tried to offload our colleagues who were fully on the COVID side and manage all that activity for them. And that included, in various trusts, you might have people who are shielding or for their own health reasons or whatever. And I've heard a lot of comments and from in-person interactions about, those people have been doing all the virtual clinics, and the people in the hospital have been doing all the hospital stuff. And then if someone's unwell or has to take 2 weeks off, they're swapping things around. So that's kind of, but what we found was actually a lot of the ERS nosedived, and we had very little, I think we had much less activity on that front than we would have expected actually at that time, which was interesting. So I hope that answers that one. And the second question was about, Ramzi, your question was about the divide between type 1 and type 2. So I think at the height of this, when we started planning this project, if you like, and trying to get it through, the vast majority of it was type 2. We saw very few type 1s coming in. I have seen some reports, and some of you are aware there's a WhatsApp group which has a number of consultants on it, and there are some reports of an unexpected increase of new type 1 diabetes in the post-COVID. Some people are reporting it, some people are not. Some people have had a year's worth of type 1 in 2 months. But you know, the vast majority of, I think a lot of the type 1s were staying at home and were scared to come in, or managing relatively well. And the people who are coming in are people who are having frequent DKs anywhere, who are in the red risk group, who actually may well have had access to sensors anyway routinely because they were in that high risk category. But I think most of this is directed to the type 2s, which does mean that we have to be really careful about the expectations, but not let that get in the way of what is a good initiative, in my opinion. Now, the other thing that we discovered was when we talked about virtual consults within the hospital management stream, we realized that what the hospital thinks is a virtual consult might be not be what we think it is. So, you know, for us, we would think a virtual consult was a video consultation, whereas different departments in the hospital, so for some people that was just a telephone consult, some people that was email clinics, some people were actually billing remote note review and MDT discussion as virtual consults. And if you look online for virtual consults, a lot of the virtual review is about when, you know, specialist care works with primary care in virtual consults, reviews their complex cases and gives them advice. So I think when we're talking about virtual, we have to be very clear what it is we're talking about that has some implications on costing, funding, and just clarity of discussion. And when I was looking for, I thought I should look for some articles, look for the net and see what's being done, not just talk about what we did at King's. And I found this article from 4 years ago saying virtual clinics launched across the UK, and then I realized it was based off a presentation done by one of our nurse specialists from King's anyway. But for us, it wasn't a big call because we'd moved 30% of our activity to nurse-led virtual clinics anyway in the last year. So we did about 3,000 appointments virtually last year. And the way we planned on these was, you know, you see your doctor once a year, or you might see me or one of my colleagues, and you make a plan of action. And then that is the implementation. If you're working on adjusting basal rates or you know, doing whatever you need to do, it's short, sharp follow-ups where you really agreed, okay, let's check your mean glucose, your time in range, or your number of boluses, and let's build that up, or let's test the basal. Is it okay? Yes, no. Short, sharp virtual consult. So it wasn't a big leap of faith for our patients to get those appointments done virtually, but we're aware that a lot of other clinics are not used to this, and for those patients, it was a big leap to not see patients, their doctors face-to-face, but speak to them over the phone. I thought it was useful to draw guidance. If you go on the BMA site, there's some advice on home working, which is, you know, making sure you have a discrete account login, use a strong password, don't store confidential patient data on your home computers. Some, you know, confidentiality tips about when you are doing, particularly you're doing virtual clinics from home, which is what I've been doing. Some advice on how you manage that. And then NHS England also gave some guidance out there. So these are useful reference documents to look at. I think quite a large proportion of clinics are using the NHS Attend Anywhere system, which I quite like. I think it really replicates the physical space in the virtual world. You've got a waiting room, and actually there's some advantages because you can see on the right here, that's just a cut and paste or a screenshot from my phone. So we might have 4 lists running virtually now. Me, a couple of research fellows and a nurse. We have a little WhatsApp group on the side. And so on the list, if I see I'm running late, I'm in consultation with someone, I might just text and say, can you pick up the next one? If there's a question that goes between them. So very much like we do it in an MDT clinic, where in a consultation, if I've got a question about cannulas, I'll just say, excuse me, wander across to the nurse, knock on the door of Geraldine and say, you know, I just got someone with this sensor issue, can you sort that out? And we're able to do that in this virtual world by bringing someone else into the consultation or swapping patients between each other. And we get a ping when everyone turns up in the waiting room, and you can even send them a message saying that I'm going to be 10 minutes late, hold on. So this is now how my clinic looks like. I've not actually been to King's since the 9th of April. I've been once for something else, but all my clinics have been done from my study at home. And so, you know, you've got your Attend Anywhere on one screen. I think to do this at home, you really need 2 screens and preferably 2 large screens. I've seconded my son's 32-inch television so I can put screens side to side. I'm toggling one with, we need a VPN to get into the hospital network so I can look at electronic patient records. I've got another screen with LibreView coming through, and I can screen share that with the patient if I want to. Headphones to maintain confidentiality. The patient also sees that you've got the headphones on, so and you don't shout as much, I think. We've got the headphones there. I have I've got trousers on that one. You don't know what's underneath the jacket, but I think it makes sense. I don't quite like the idea of doing a consult in a t-shirt, actually. Make sure there's light there, and the first few consults, you know, we just sit there in a room to see the screen. You have to put the shades on because the sun's blinding your eyes, and they say we can't see you because it's too dark. So just now I've got a spotlight aimed at my face there, so there's light and you can see them. I prefer the virtual backgrounds again, so that if kids or partners wander in, or you see something, it doesn't affect people. Coffee is always required. It's quite tough actually sitting there going through patient after patient. You have to concentrate much harder in a virtual consult than you do in face-to-face, I think. So, you know, our lessons learned were that triaging and creating lists was a challenge. I ended up seeing people, or our team of 4 clinicians who were managing the workload, ended up seeing people we didn't know. So effectively, they were all new consults. And gaining the trust of people was challenging, but people were really forgiving. People were really thankful that we're looking after them. Maintaining availability and creating lists created an administrative challenge for our secretaries who work beyond, over and above, to keep us running. Getting the right contact details was a challenge. And we lost a lot of appointments, a lot of DNAs because we had the wrong contact details on the system. And because we were creating the clinic with a short turnaround time, people weren't getting the letters in time. Setting up the VPNs and just getting the tech set up, getting double screens and things was a big challenge. But a big plus was working from home. So, you know, I got 2 extra hours in my day. And this was really key for us because we didn't have a room in the hospital to do these clinics. So we had to get the VPNs done. I'd say to the trust, look, if you want us to look after patients, you need to get us VPNs to see them at home, because there physically isn't somewhere in the trust where we can see them. A lot of our consultants were in shared offices where, you know, capacity-wise, social distancing-wise, you couldn't have 5 consultants doing 5 consultations in those offices. I think we have found changing insulins and medications very tricky because prescriptions, pharmacy, ordering bloods, all of that stuff is quite difficult. And then I didn't realize what a big issue it was doing clinics from home is outcoming them. You know, because at the end of the day, what the hospital calls catching up, you know, need another follow-up, have you seen them, when's the next, how do you manage that? And luckily our IT team worked quite well to develop an e-outcoming system for us where we could book their next clinic online. But moving forward again, as we start getting some of our space back, if we have to maintain 25% capacity in our buildings, we can't. The logical thing would be to put all your face-to-face patients in one list and do all your virtual clinics from home, so that I minimize the number of days I have to go back into hospital, minimize my risk, my colleagues' risk. But actually, it doesn't work that way, because if you can't have 6 patients on a list who can come in, or 8 patients on a list, because then the social distancing won't work. So we're now working with blended lists where we have a couple of face-to-face ones for those people who need it, and the rest are virtual. We also found that people were given letters or appointments for virtuals, but they're just so used to turning up to the hospital. So we had a lot of walk-in people, so we had to maintain some presence on the ground. But also for people who, we picked up one where things just weren't making sense. He was giving insulin, but no result. And so we brought him in, and he had a huge lipohypertrophy that we picked up on examination. So we have to keep some walk-in capacity there. Further tips and thanks to our senior nurse Geraldine and my colleague Marietta Stadler for these. Internet bandwidth was an issue for one of our colleagues. Again, think of the background. One of the doctors got a comment that having a shelf full of lovely kids' pictures was unsettling for that person, and having no light. So again, how you look into it, and then tabs, making sure we have access to all our kind of data tabs, and supporting people to upload data before clinics is useful. A lot of people didn't log into the Attend Anywhere, and so I'd say 50% of the appointments were done by phone, and so it's important just to kind of turn your caller ID off when you're calling patients as well. That was another thing that we had to protocolize. And then in the consults, for those of you who are setting these up, it's very simple things, isn't it? A lot of times we're speaking to people who don't know, so check the identity. If there's someone else there, we just have to check they're okay to talk. Maybe suggest to them you want to wear headphones so we can have this conversation a little bit more privately. And then if someone wants to say something, we've had circumstances where the patient wanted to mention something, so the chat function, Attend Anywhere, helped in that setting. Also for us to give people resources. So, often in the chat section, I'll be typing out, have a look at DTN online videos, have a look at the Bertie online. If they've not done Daphne, have a look at the T1 resources videos. Go to the Diabetes UK website for information. So just copying and pasting these tabs into the chat function for those people to click on. And then I'd say click on that tab and then save it in your favorites so you can find it next time you want to look at it. And then, as I said, we've got a WhatsApp or Pando app to communicate between clinicians on the clinic, so we can swap people around if we need to. I think it's also important, I just setting these clinics up, and these are things we learned and changed as we went along. But now in the letter going out to people, we're asking them, look, please can you take your weight before clinic? If you've got a blood pressure machine at home, can you take it so we can just record those things that would happen normally in a face-to-face appointment? Can you make sure you've got your GP prescription there? If there's someone you want to be there to understand and discuss, have a partner or a parent there. And often we've actually found that's been very useful. The sort of person wouldn't naturally take time off to come to clinic, but because they're there in lockdown, you've got a better picture of what their home situation is like, who's with them, what support they've got. And then, of course, uploading data as required. There was a link down there at the bottom of the screen for a home foot check as well, which I've used a few times just to say, right, okay, or I've used a partner to do a foot check in people where I'm worried about that. The other thing we've used a lot to categorize our patients in triage is we've used LibreLink. So we had a few hundred patients on LibreLink, and I've blocked out the names, of course, but you can see here, we've got some people who are struggling with their diabetes, who've got average glucose above 15. And so those were immediately on our red list to come and work with and see how they're doing. And that was very useful, I think, just to highlight those patients. And this was just a case that I wanted to highlight to you. This was a young 20-year-old patient, young girl, who had multiple DNAs to transition clinics. I think she'd made one appointment in the last 2 years. She'd been given Libre, but using it very on and off with, understandably anxiety, depression, social issues carrying on. Hated coming to clinic and that whole atmosphere. And she triggered red on triage because her last HbA1c was 13.8%. And you can see when I first saw her early June, her mean glucose was 17.8% plus millimoles rather, with 8 hypos with a huge amount of variability. And okay, things aren't perfect, but actually in a month, you probably wouldn't want to go any faster. But you can see here in that high risk patient, saw her, made some comments, got a 2-week appointment back in the virtual clinic. Very short, sharp appointment actually. So how are you doing? Let's see where you're going. And what you can see there in the shape of the traces, I hope, is if you look at that bottom trace there, what you've got is a big dose of insulin at bedtime, bringing things down, occasion to hypoglycemia in the morning, food with no insulin in the morning, maybe 1 dose of quick acting down here in the evening, and then some food at bedtime to bump it up again, and then a big dose of background to bring it back down. That's the pattern that I can deduce from that AGP. What you've now got here is maybe there is at least some nova rapid happening here. The nighttime is flattened out a bit on the median. And we're getting the insulin in, we moved up from 1 nova rapid a day around about here to maybe 2 here. And now you can see that median line flattening out. That time right above there, above 20, started to come down. Still got an issue with the evening meal or a snack after evening meal, not quite sure what that is. but you can see now breakfast and lunch getting much better, average glucose dropping by 4 millimoles. And actually, if you look at her last AGP profile, you can see now she's up to an estimated A1C of 9 point, or down to estimated A1C of 9.5%, the first time she's been in single figures for the last 7 or 8 years. And this was someone who we could not engage in face-to-face clinics. Now, of course, part of the reason we got hold of her was because she was in lockdown. And so when we rang her, she contacted us. But I think the feedback from getting to know this person, who I'd never seen before, I've never physically seen the person at all, actually, because she declined to use the video function. So we just talked over the phone, and she found phone far less threatening. And with these patients, I just want to highlight, I know we all kind of see an HbA1c of 14% in a 20-year-old girl, and take a deep sigh in. We've all struggled with these patients. And I just wanted to share a couple of tips that I found useful in helping, supporting a number of patients in this sort of category. I think focusing on the process rather than the results. I think something that was really important that she's mentioned and others have mentioned before is saying that you're taking 1 shot of background, placebo once a day, and you're taking 1 Nova Rapid. You're going to get readings. At the moment, your HbA1c is 14%. Most of your readings are going to be 15 to 30. But I don't really mind that. I just want to know how many scans you're doing and how many injections you're doing. I don't really care what the number is. Put a hand over it. That's not important. And we're just going to build on that. And that's the thing if I say I'm going to see you in 2 weeks' time, I just want to say, can we get to a mean of 2 a day? And then a mean of 3 a day? And just work on these short, simple targets in a short time frame. So these patients, I try wherever possible, never to leave it more than 4 weeks. 4 weeks, I think, is the ideal time frame to see them, where you give them a target and they can just about keep that going for 4 weeks, and then they can see the benefit, and then they might work a bit further. Sorry, Ramzi, you're going to...
Pratik, 5 minutes.
Okay. And so what's the time and range? We talked a lot about simple apps, and I want to show you, this is an app that I really like for use with the Libra, which is Diabetes M. And the reason I like it is because you can download it. You can put in your glucose that you get from your Libre, but you can also put in the arrows, and it will make an adjustment based on the arrows. Put in your carbs, and it gives you a dose there. So again, even if people are not carb counting, I'll just say, look, just put in 50 grams every time. And at least it will work. It'll do a correction, and it'll be better than people taking random doses. We've done a lot of virtual tech starts. A lot of people thinking, how can we convert our Libre start groups into face-to-face groups into online? And we decided trying to do it in a group is very difficult. Why don't we just let people, we email them the documentation, so they send it back. So they've got to fill in their baseline DDS, gold score, HbA1c. We tell them to go to the Abbott Academy and the DCN videos. They self-certify they've completed both. And we spoke about the sensors, 6 weeks of review with the repeat data and transfer of care. So we've got rid of the whole group aspect and done the training online. And actually that's been a great success. There's a rather more complex pathway for how we start pumps. And that's the next project. This pathway will be on the ABCD website. And what I'm trying to get done is a virtual showroom of all the tech from all the companies. So the main thing is maintaining patient choice. So they have a place to go where they can see, well, this is the advantage of this pump or that pump, and then work using the companies to do a lot of the technical training. And so that the clinical knowledge checklist that the specialist nurse would do is minimized. So instead of spending 3 hours doing a lot of the technical training, we offload that to industry, and we can focus our very important DSN time on doing the technical training or doing the clinical training. So I think virtual clinics are here to stay. I've just been hearing that in many places, admissions will operate dual categories. Certainly in Scotland, that's the case, where COVID and non-COVID, which means diabetes clinicians are going to spend a lot more on the front end, which means our capacity is going to be reduced. We're going to do a lot of virtual stuff with blended patients. I just want to repeat my point about right patient, right time in the right way, and just some tips about being prepared, phones, location, downloads, and getting people used to that new normal. So that's all I have to say. Hope I was in time there, Ramzi. Thank you.
Well, thank you very much for that, Pratik. That was absolutely fantastic. So we had quite a few questions. So starting with one of the very early ones, you mentioned that some people suggested that the blood glucose levels improved during lockdown. So what work has shown that, and in which countries was that work undertaken?
So it's a little bit cheeky, but I've reviewed 2 papers where they'd submitted some data using various, let me not say, they were using some form of glucose monitoring. Actually, papers were using all 3 Dexcom, Libre, or Medtronic systems, just showing that glucose control maybe 0.2% better during lockdown compared to a similar time afterwards. So that was just an anecdotal thing. And then anecdotally in clinic, I think people have said that, yeah, I'm not commuting, I'm controlling what I eat, I've not got stress, I'm maybe not working or whatever. So glucose control has been a bit better. On the other hand, I guess people with a lot of financial issues, there's always that spectrum, isn't there?
Were these papers from the UK? Because I reviewed a few, but I can't remember reviewing anything from the UK.
Not
Right.
from the UK.
Okay. Right. So the next question
Maybe
was
we're
about
the same one.
possible. The next question was about mental health and A1C. Sort of, what's the evidence that mental health can be assessed as A1C? What's the evidence behind that?
There's actually a paper published by us a while ago where when we started doing diabetes distress marking, we found that surprisingly about 30% with a HbA1c below 7.5% described high distress. But if you go to the category of A1c between 7.5 and 9, that's about 50%. And if you go to 9 and above, that's about 70% have a diabetes distress score of 5 or 6. That's my internal data. Actually, there's a lot of papers showing that A1 distress tracks with A1C. So it's a 2-dimensional 2A relationship, right? If you've got a lot of distress, you're finding it hard, A1C goes higher. If your A1C is high, you think things are, that makes you distress as well. So I think it's a 2A relationship there.
Yeah, and I quite like the fact that you included hypoglycemia in that as well, because I mean, it's both things, isn't it? Right. Okay. One of the questions was, which platform are you using for your virtual consultations?
So I showed you we're using Attend Anywhere, but I must admit, the patients get a request saying you've got an appointment with one of the clinicians doing the clinics. And I kind of wait for 10 minutes. If they've not logged on, I get a sheet printed off with their phone numbers on it, and I ring them. And I reckon I'm ringing 50% of them and doing 50% on Attend Anywhere. Some days, some weeks, everyone comes on Attend Anywhere. Some weeks, no one does. So I think you have to be ready to call them. Not everyone is confident with the with logging on and doing the Attend Anywhere thing. Yeah.
Okay. The other question was the use of Libre in type 2 diabetes. Is this something to consider in people who are insulin deficient, i.e. behaving as a type 1, particularly when they're on a QDS regime? So what are your views on that?
So when you go around Europe, anyone on insulin is allowed access to Libre in France and Italy, pretty much, right? Some other countries have got it very tight. So I think that's a much more political discussion. I guess technically the place where you really need that data, and to my mind, you're right, it is when people become insulin deficient, but we don't measure the insulin deficiency that much. But insulin dose doesn't tell you whether they're insulin deficient, right? So there's lots of people on 200 units of insulin a day who actually have C-peptides of 4,000, and they're just hugely insulin resistant. And I'm not entirely convinced those people need Libre. It's the insulin deficient end of things. And actually, probably the best clinical marker of insulin deficiency is hypoglycemia. And if people are having hypoglycemia, they are probably insulin deficient. And whether we move in that direction over time is dependent on a lot of different things, isn't it? But certainly, we've done a few people where they're having problematic hypoglycemia called type 2, long-standing type 2, measured a C-peptide below 400, and that's not that different from a new type 1 in that sense of having hypoglycemia, whether you reclassify them. And this whole idea about the heterogeneity of type 2 diabetes, isn't it, from the Swedish data, might move us in that direction.
Okay, so there was one question about stratifying patients according to the patient activation measurements. So what are your views on that?
So it depends what you're stratifying them for. And I think when we were discussing our risk stratification levels, both internally in King's, then in this wider ABCD document, we had to, you know, as you start getting into, well, why don't we stratify, add this factor and that factor and that factor? We kind of came around to the conclusion that what is the purpose of the stratification? So if the purpose is to stream them into a mental health service, then you need to know what their mental health issues are. If the purpose is to stream them into a education program, maybe their self-activation is a fundamental issue. At this point, if the focus was, there's a COVID issue out there, we don't want people coming to hospital, so the people we want to triage and highlight are people I want to work with are people at the highest risk of admission and people at the highest risk of death from COVID. And the best marker for the 2 or 3 best markers for that were HbA1c, previous admission, and GFR, because those are the mortality factors, really. Maybe we should have said age over 70. We discussed whether we should put an age over 70, and it kind of came back, well, if the person's over 70 with an HbA1c of 7% and no hypos, then does that really make them red? You know, if the patient activation is low, but they have good HbA1c with no hypos and good kidney and renal function, then in this COVID medium to long term till mid 2021 next year, we, you know, if you can see them, it's great, but if you have to prioritize people, they'd be slightly further back than people with high biomedical risk, my opinion.
So regarding, there was an exclusion of pregnancy and foot in your virtual clinics. Does that not feature at all, or?
They were outside of our consultant-led triage picture because actually the pregnancy service continued as it was. And you know, the pregnancy team, as it were, managed the pregnancy patients. So certainly at King's, we have 2 clinicians who deliver the pregnancy service. The rest of us doesn't get involved with that, and they manage their service as it was. So we didn't take on triaging their patients or triaging the foot patients. Those services did their own thing. But what we did, what I did with my team, what we did was we looked at everybody else. So, you know, we've got 12 consultants who, and most of them do kind of mixed clinics. Someone has a type 2 clinic, someone has a post-transplant clinic, someone has a renal GFR 30 clinic, my type 1 clinic. So those are all the people that we looked at. We thought we shouldn't be triaging pregnant women. We shouldn't be triaging people with foot disease. They need to be seen.
Fair enough. Now comes a really tricky question, and this is something really close to my heart, actually, is about sort of, we adapted to COVID by doing the virtual clinics. What about SPR training? What are we doing with that?
That was a huge problem, wasn't it? Because our SPRs got just pulled into general medicine. They were on the wards. They were all decked up in PPE. And now I think from the 1st of July, really, we're getting them back into clinics. And so we just had a lot of discussion about how do we train them. And to my mind, you know, there's nothing. So what we've come up with is probably in Attend Anywhere, you can invite them into a consultation. And so they can sit in for a week, or for 1 clinic or 2 clinics, and then you can give them a short clinic where they can see the patient and then you go in. So anyway, the way I used to run my clinic was, if I had a registrar and a research fellow, I'd get them to see the patients and I'd float between them. So they would get the information, go in, yes, I agree with what you're saying, or let's try this, and then go to the other one. And so you can do that with Attend Anywhere. And I think the mindset is to recreate the physical activity in the virtual space. And I've tried to keep that tagline there wherever I could. Yeah.
Okay. So the next question, which I think is quite an important question, is, have you done virtual MDT clinics?
So on the MDT story, so I must admit, some people, particularly in pump services, run MDT clinics where there's multiple people in the same room. And we've always never had the capacity to do that. So while it'd be great for me to sit in with my dietitian or my specialist nurse and see a pump patient, that's just a very, very resource intensive way. And so the way we've always managed that from a long time ago was that we try and make sure the right person sees the right patient. It's the right. So, you know, if it's a patient who I've seen and the issue is around carb counting, then I make sure the next appointment is with a dietitian. So rather than a one-stop shop seeing someone once a year, I prefer to them to be seen thrice a year, but by seeing the right sort of person. And then at the end of clinic, what we've always done, and we just, again, recreated our physical activity in the virtual space, is at the end of clinic, we have an hour's MDT where we quickly run through any issues.
Yeah.
And so that's the team MDT. And I'd say to the, I've seen this guy who's got a, carb counting just all over the shop. So this is the name, this is what you need to do. Can you give him an appointment? Right. They've seen someone with a medical issue, they ask me, and we just run through what changes you've made. And that way the team stays together and works to, and there's a lot of exchange of information in those MDTs actually, where I learn a bit about carb counting and they learn a bit about some of my crazy ideas.
And would you say that you can get away with some patient not seeing them at all, or do you feel that everybody should be seen at least once a year for safety reasons?
So I think there's two big debates, isn't there? Two camps, and there's a bunch of people who I've seen told, no, we've got to see them at least once a year. But actually, and certainly, I work in a tertiary referral center where a lot of my patients, 50% of my patients are out of area. And even when they're not, particularly so let me put it this way, people in the red category, you need to be seeing frequently, right? Okay. And then in some of those contacts, I think you should be able to do a face-to-face and just get all the routine stuff done, right? And then you come down to the green guys who you're seeing once a year. And I actually think that it's quite useful for them. The poor GP is prescribing their medication. GPs are fantastic at doing foot checks. If they're green, basically their stuff is going to be okay. Their kidney's going to be okay. Their bloods are going to be okay. So actually, those are the people where I'm very happy for them. Say, okay, I'm seeing you every November, 6 months time. Think of 6 months time. Try and fit your GP annual review at that time. Get the annual review done by the GP, so they can put it into their national diabetes audit. They get their bonus. They get their Mercedes, and we do the glucose. And I don't have to bother about your feet and things, which are going to be okay. As soon as they're abnormal, that's when you let me know. Yeah. So, and in that scenario, then, if I'm just doing the glucose, I don't need to, for a green category person, I just need to see that data. And I need to be able to chat to them and see what's going on. So I think, so my opinion is that the people in the red ones are the ones where something is going to be wrong, where it is important to see them and pick up those little non-verbal cues or just examine them and see what's going on. But as you get down the scale, the need for face-to-face reduces rather than kind of, and same with new patients. We've had a lot of discussions about whether, well, every new we should see them face-to-face. But actually, if the GP has done a review, done the foot check, done the bloods, then I just do the glucose in type 1.
So last question, because we are running out of time, is if I just press you a bit and you say, these are the patients who have to be seen face-to-face, who would you say that we have to see them face-to-face?
Well, it's when they can't do the virtual. So there's a lot of people without the technology support who you have to see. That's a straight no, where the patient says, look, I can't do the virtual for this, that reason or the other. I think if you've done a couple of virtuals and there's not moving and you need to see them face-to-face, I think that's where you should see them. Even the bloods, there's nothing stopping you getting the bloods locally and getting the results. I don't need the blood to be taken at King's. I just need to see the results. So I don't think there is a hard and fast, apart from the fact that a patient who doesn't have an iPad or doesn't have a phone or won't use a tech. It's much more on the patient side rather than on the biomedical side, because I think a lot of the biomedical things you can get around.
Fair enough. So I'm going to hand back to Hope for the last bit, just to close the meeting down. Thank you very much, Pratik. That was really very useful. I personally learned quite a bit. Thank you.
Thanks, Ramzi.
Thank you both so much. I can see the messages of thanks coming in. So it was really, really useful, insightful and enjoyable as well. So I hope that you all enjoyed it too and took a lot away from it. I would like to thank Abbott once again for kindly sponsoring this webinar. So thank you all once again for joining us, and thank you very much, Pratik and Ramzi.